We are going to discuss risk of bias. Risk of bias is an important step that is being performed in systematic review and meta-analysis. Before we understand how to conduct this step, we need to know what is bias. So could anyone in the chat let us know what is bias? What do you understand by bias in a study? Also, while we wait for answers, I would like to tell you that we are going to divide risk of bias lectures into two parts. Today, we are going to understand the process of risk of bias through examples and questions. And in the next set, so after this session, I'll give you some tasks that you'll be supposed to do, some training modules. And then in the next session, we are going to learn how to enter information into our Excel sheets. So we got an answer. Quality assessment of the included studies. Yes, so that is risk of bias. Thank you, Amrit. A preconceived notion which affects our thought process. Nice, thank you, Zuha. Okay. Bias overall refers to any prejudice that may affect data quality. Yes. Bias is pitfalls during research, before research, or after research. Very, very interesting. Thank you for sharing your views. So you all understand what bias is. And it's basically systematic error or deviation from the truth. Everyone has given their answers, which is exactly or similar to this sentence. And what is not considered a bias? We are going to understand that as well. So any systematic error which tends to skew our outcome and our data in any one direction, that is called bias. But if there is a random error or there is lack of precision in a study because of small sample size, then that a random error can skew our outcome in any direction. And that is not considered a bias. Bias is something that can alter a research result and lead to a different conclusion. Yes. So thank you. Great. Now that we understand what bias is, we are going to talk about types of bias. So could you all mention in the chat box, what are the types of biases that you know, or you have learned about, or you have even heard any type of bias? Also, if you're unable to hear me, you can click on the down arrow beside the mic, and you can select built-in microphone, internal microphone, if you're coming from laptop. So I think that might be an issue, or you might have connected to Bluetooth somewhere else. All right, so we got answers. Attrition bias, yes. Reporting bias, yes. Memory bias, interesting. So you mean recall bias? Yes, correct. Tower of Babel bias. Oh, wow. Vishnu, I would like to ask you if you could elaborate this. Tower of Babel is something new to me. I would like you to elaborate. Selection bias, yes. Observer bias, confounding. Sampling bias, selection bias, amazing. Great answers and correct answers. So now, exactly as you all mentioned, we have 5 main biases. So bias and confounding. So biases and confounders, these are the two things that can change the outcome and may provide you false outcomes. So selection bias, it occurs when we assign patients to treatment groups. Performance bias. Performance bias occurs when we give them a treatment or when we perform a diagnostic test or any intervention or exposure that is happening. Detection bias. Detection bias is when we are assessing the outcome after exposure or intervention. Attrition bias. Attrition bias occurs mainly in prospective studies. That's cohort studies and even clinical trials. So anything which requires follow-up can lead to an attrition bias. If patients are not able to, if there is a loss to follow-up. And then we have reporting bias. Reporting bias is when all the outcomes are not reported in the study, only some of the outcomes are reported. I'll have to mute some people. There is, yeah, perfect. All right, so now we will go back to questions. I hope you're able to see this, or do you want me to zoom in? Please let me know what type of bias is this. Out of the 5 biases that we saw: selection, performance, detection, attrition, and reporting. Out of these 5 biases, which type of bias is this? I'll read it. A patient learns that they received the placebo treatment in a study. When they are performing a visual acuity test, they consciously or subconsciously do not perform their best due to knowing they received a null treatment. We got answer for Tower of Babel bias. Non-English studies being excluded. Wow, thank you so much, Dr. Vishnu. That's amazing. Okay. Lajja, you can leave this Zoom meeting and rejoin. I think that might be the case because I think everybody else is able to hear me. So you can leave the message and then rejoin. So performance bias. Performance. Perfect. So we will go back to examples. Performance bias when they are aware of the assigned treatment. Perfect. What about this one? A study assessing visual acuity. Okay, wait, going back to this one. This is a red golden star question, I would say. Do you know what is this bias called as? There is a specific name given for this bias. It's not present in any of these, but it's a specific name. Which is okay, I'll give you 3 options. Placebo bias. Okay, let me give you a hint. Has anyone heard of this word, golem? All right, so when knowledge of certain information reduces your performance, it's called golem bias. Does anyone know what Hawthorne bias is? Hawthorne. Would anyone like to answer this? Hawthorne bias. Till we wait for the answer, I'll skip to the other slide. Just one moment, please. Okay. So Hawthorne bias is, it occurs when patients know that they are being watched. So yes, Dr. Zuha, behavior which changes under observation. Loss to follow-up is a bias which we will see later on here. Attrition bias, that is called attrition bias. Okay, moving on. This question. A study assessing visual acuity after retinal detachment has a large number of withdrawals that occurred so you answered that. Jai Prakash answered this question. Occurred primarily in patients of lower socioeconomic status. Yes, Arushi is correct, attrition. So you have an idea about attrition bias. Now I would like to modify this question. has a large number of withdrawals that occurred primarily in patients of socioeconomic status. Now, what if I remove this? Now, what type of bias would this be? Or would this be considered a bias? I have removed this part. Occurred primarily in patients of lower socioeconomic strata. Why is that sentence or that part of the sentence very important? Okay. Sample size. When we reduce the sample size, the results become less precise and results tend to be deviated in either side. So Nicholas is correct here. When we remove the part about lower socioeconomic strata, patients can be lost to follow up from either higher socioeconomic strata or lower socioeconomic strata. So the results can be skewed in either direction. So it will no longer be considered a bias. It will be considered an imprecise study. So Nicholas is correct. Withdrawal is not random. So actually, when lower socioeconomic strata is removed, withdrawal becomes random. And when that part, lower socioeconomic strata, is added, the withdrawal stops becoming random. So Arushi is correct when we add that particular part. Thank you. Moving on to this question now. A surgeon in a glaucoma laser versus topical medicine randomized control trial can accurately guess the allocation of future patients. They may then preferentially wait to identify the ideal patient for each treatment arm, opposed to having them assigned at random. Selection bias, selection bias, selection bias. Okay, let's move to this. Great. So we are done with performance bias. We are done with attrition bias. We are done with selection bias. You guys are really good at this. Better than me, actually, but okay. Sorry. What about this? A published RCT on cataract surgery stated that they would assess visual acuity, adverse events, and quality of life within their protocol. However, only visual acuity and adverse event outcomes were reported. Reporting bias, amazing. Yes, very fast answers we are getting. All right, so you got an idea about how to understand what type of bias it is. Moving to this. This would be the last example. After that, we'll be moving on to another segment. A surgeon grading post-operative inflammation in an ophthalmology RCT is not masked to the patient's treatment, and this knowledge influences their assessment based on prior knowledge and experiences. Performance bias. Perfect. So you have an idea about the types of biases. Moving on to the next part. We discussed this before. What is not considered a bias? So imprecision, random error, which occurs because of smaller sample size or a very wide confidence interval. Quality. So if the studies are not well conducted in terms of the type of study that is being used. So for example, a particular study might be better conducted through a case control study because, for example, the disease is very, very rare. So for very rare diseases, we usually use case controls, but that study is using a cohort study type. So that might reduce the quality, but it won't create a bias. Then reporting. So reporting bias occurs when you selectively report only certain outcomes. But when there is some issue with reporting, for example, for all the patients, one particular variable has not been collected. Say, for example, if I want to assess the prevalence of um, a certain side effect after a drug ABC, and I do not assess for a very, very common, if that drug ABC has a very common side effect called like nausea, and I do not include that in my paper, it won't create a bias, but it won't be a good quality paper. All right, coming to Cochrane risk of bias. I hope everybody is aware of this organization called Cochrane. It is an amazing organization which teaches you in a very, very detailed manner about how to conduct a systematic review. If you are not aware of Cochrane, please go on the internet and check it out. It has an entire book on the internet about the different steps of conducting a systematic review and a meta-analysis. So risk of bias is assessed under 7 domains. We will go through them one by one. And for each domain, so all the 7 domains will be applied to every study that you are adding to your systematic review. If you are adding, say, 57 studies, then all these, each of the 57 studies will be assessed for these 7 domains. And for every domain, you will either pick low risk, high risk, or unclear risk. So these are the 3 options that you get. In addition to mentioning what level of risk is present in the study, you will also mention your explanation along with, so explanation plus minus evidence quotes from the paper. So you have to mention why is this low risk, why is this high risk, or why is there lack of clarity regarding a particular domain. You have to mention that in the space provided to you. So these are the 7 domains: random sequence generation, allocation concealment, blinding. Blinding is of at different levels of participants and personnel, blinding of outcome assessment, incomplete outcome data, selective reporting, and then other biases. Now we will go through them one by one. So we are only going to talk about randomized controlled trials in this session. We are not going to talk about observational studies. Towards the end of this session, I will talk to you about the grading tools used for observational studies as well. Okay, so before we start a clinical trial, we select our target population, then we allocate the participants into 2 groups, interventional group and control group. Then we give them either placebo or the intervention, and then we assess the outcomes, and then we go to publication of the study. So right in the beginning, selecting our sample from the population and allocating the participants into different groups, there are 2 biases which can occur in this step. This particular bias is selection bias. You all know what it is. Random sequence generation and allocation concealment are assessed in this step. So first we'll talk about random sequence generation. It avoids selection bias. So if it assesses how the patients are allocated. So how the patients are allocated into different groups. And through examples, we'll understand how this is. Here you go. So I want you all to assess, if I am doing a study and I mention that in my clinical trial, we are going to use coin toss to assess patients. If heads, the patient is put in the intervention group. If there is tails, then the patient is put into placebo group. What would you consider this type of sequence generation? High risk, low risk, or unclear risk? I want you all to mention here. So till you all answer, I will look at the chat box. The question somebody asked, what type of studies come under ROB2 only RCTs and clinical trials? That's a good question, Siddhant. So ROB2 actually includes only randomized control trials and not the non-randomized control trials. So I will talk about all the different types of assessment tools towards the end of this session. But just to understand the risk of bias process, I am just using ROB because it's very easy to understand. Nicholas mentioned low risk using fair coin toss. Yes. Low risk, low risk. Perfect. So everybody has answered it correctly. It is low risk. What about this one? Alternate allocation. So now in my study to assess side effects of a certain drug, or to assess the efficacy of a new drug, the first patient that comes in the morning, I'll allocate them to intervention group. The second patient will go to placebo, third patient intervention, and so on. What level of risk would you give this type of sequence generation? High risk, low risk, or unclear risk? I would love to see wrong answers also. So just make a random guess. That would also be fine. That's interesting. That's interesting. So we got a lot of low risk answers and then we got some unclear answers. Okay. The answer is high risk. The reason being, maybe I am taking very, very severe patients or patients who really, really require this drug in the morning. And then towards the evening, I'm just taking patients who are coming for other illnesses. So maybe I have told the patient that I'm doing this study, so come at 9 a.m. And the patients who are not going through this particular condition, they can come towards the afternoon, and then so it's high risk. That is my answer. Why is coin toss low risk and why is alternate allocation high risk? Because in alternate allocation, every second answer will be heads. In a coin toss, that is not the case. In a coin toss, there is a 50% chance of heads in every allocation that I conduct. But in alternate allocation, there is a 100% chance of heads in every second allocation. I hope I was clear in this. This was a question that I also had. I'm saying heads a lot of times, so that's it. Yeah, so good. This was a good example to understand. What about this? Shuffling cards or envelopes, having a blinded envelope or shuffling cards. What do you think? What is the level of bias in this one? Low risk. Low risk, yes. So you got an idea. This one is low risk because you don't know what card you're going to pick up every single time. So that is important to know. What about this? By patient's ID or record number. High risk. Okay. High risk. Okay, great. You are getting an idea now and you are becoming really, really good at this. This is high risk actually. Amazing. Okay. Moving on to the next topic. So these are some of the other examples. I will be sending this entire PDF to you on WhatsApp groups and you can go through the other examples as well. Now coming to allocation concealment. Allocation concealment also avoids selection bias. What is allocation concealment? So when I'm recruiting my patients to a study, recruiting patients and segregating them into intervention and placebo groups, I also should not know which group they are a part of. So that is a different thing. Sorry, that will be blinding. But when a patient comes in the morning, so by looking at the patient, I should not have an idea, okay, this patient needs intervention, let's put him in the intervention group. So that should not be the case. So nobody should be able to predict which group they will be allocated to. And this occurs when we implement random sequence step in a very, very strict fashion. I will explain this better through examples. There you go. So, okay, let's take this example itself. If I'm using envelopes for my study, if I'm shuffling cards or just shuffling envelopes, now one envelope is completely white, it is opaque, and I do not know what number is inside that envelope. On the other hand, the other envelope is not sealed, it is open, and it has a transparent plastic package in the front, and I can see a part of the number that the patient is going to get. So what do you think? Which study is low risk? The one with completely opaque sealed envelopes, or the one with open envelopes and a plastic cover where I can see a part of the number? Even though both are conducting random sequence generation, because in both the cases, I am shuffling envelopes and giving it. Amazing. Yes. So, but in the first case, in the opaque envelopes, I do not know which number is being allocated. So that will be a proper allocation concealment. What about this? What if a person is using identical drug containers? Would it be low risk, high risk, or unclear risk? Perfect. It will be low risk. What about this one? Random sequence known to staff in advance. So I think we just went through this. This would be high risk. I will go a bit faster now. Okay. So now you know what allocation concealment is and how to assess it. These are some other examples that are there, and you can go through it later. Coming to the other step. All the patients are in two groups, and now we are going to give them treatment or exposure. And now we are going to talk about blinding. Blinding will be occurring at two steps. One, of participants and personnel. So here, patients do not know which arm of the study they are going to participate in. Okay, let me ask you a question. What is a double-blinded study? What is a double-blinded study? You give me answer. Who are unaware of which group they are a part of? Patient and doctor. Perfect. Patient and research team. Interesting. Researcher and patient. Yes. What is a triple blinded study? This is my question to you. What is a triple blinded study? Who all are unaware? In addition to patient and researcher, or patient and doctor, which other person? Data entry person. Amazing. So data analysis person, outcome assessor. Perfect. So you have an idea about blinding. We won't go into detail. Let's have a look at this then. This is my question to you. If a study is not conducting any blinding or has incomplete blinding, what would it be? Low risk, high risk, or unclear? Now, I would like to mark a point of caution. I'm not going to ask you such a simple question. That is all I'm going to say, but I want you to answer. And why would it be, if it is unclear, what other thing you would be looking at? What specific thing, or what, to make it more clear, what would you be looking at? One thing is missing in this sentence. Go back to what is considered a bias and what is not considered a bias. Go back to that and then answer. What else do you want to know? If this can be considered a bias or not. Study design. That's interesting. Would you like to elaborate on that? There is something that I'm looking for. I can give you an example. Okay. Actually, by giving an example, I might confuse you. What are we reporting? Yes. Types of outcome. Yes. So, yes, we are there. We are there. If they are reporting on causation, then answer is preferred. Yes. So, if we look at study design, that will not be considered a bias. It will lead to a low quality paper. So scientific quality will definitely be low. You are right. When we talk about bias, we need to know if blinding is not conducted in a particular clinical trial, will that affect the outcome? And in which direction will it affect the outcome? So two things we are looking at: magnitude and direction. Just like vector that we used to study in physics in 11th and 12th, the magnitude and direction will look. Mainly direction. So is it going to skew our results in one direction? Then it will be called bias. Perfect. Okay. Moving to the next part. Blinding is very, very easy, and most of the studies mention it, that this is a double blinded study, this is an open trial, this is a single blinded study. Don't just go with this is an open trial. Oh, open trial, okay, it will be high risk. No, look at the outcomes. See if the outcomes are going to be skewed by open trial. This will come with experience. So you will need a senior researcher helping you out at this step. Talking about blinding of outcome assessment. So right now we talked about single and double blinding. This is triple blinding outcome assessment. So it's also very, very simple and very, very direct. So the person who is assessing, now who all can assess the outcomes? It can be the doctor if they are looking for signs, if they're looking for lab reports, if they are looking at imaging. It can be the patient as well. If we have a survey based clinical trial, not a survey, sorry, a questionnaire based clinical trial, or patient reported symptoms, then it will be the patient. The outcome assessor will be that. And it can be a third party. So understand who is assessing the outcome and understand if they know which arm the patient is a part of. That's very, very, this part, low risk, high risk, is very, very similar to the blinding we saw in the previous slide. So we are not going to go into detail. Now coming to attrition bias, incomplete outcome data. Let's go here. Now I want all of you to just give me a definition or a simple, what do you understand by this term? That's all I want to know from you. Intention to treat analysis. What is it? What do you understand by intention to treat analysis? Okay. So if you know any of these, per protocol analysis, as treated analysis, imputation, you let me know. You mentioned here. These are outcome measures. Yes. So when we are analyzing data, the statistician, they follow one of these four paths. Let's talk a bit about these four paths then. Okay. Here you go. Intention to treat analysis. So if I am conducting a study to understand the effectiveness of a drug ABC, then, and I have assigned 50 patients in the intervention group, 50 patients in the placebo group. Down the line, it happens that 10 people from the placebo group and 9 people from the intervention group have been lost to follow up. Even then, when conducting data analysis, I will still go with 50 people in the treatment and 50 people in the placebo. I won't be removing the 10 and the 9 people from each group. I will go on my intention that we intended to treat them. There is an answer. If your intention is in favor of treatment, you tend to report all the positive outcomes only. That will happen when there is no blinding. So if I know that I want to treat this patient, then I will only report positive outcomes. So that will occur in blinding. That will occur when there is no blinding. But if it is a properly triple blinded, proper blinding has been followed, allocation concealment is there, then nobody knows what treatment the patient is getting. And then at data analysis, we only look at who all are lost to follow-up. And that is what we focus on. So in the first path, we ignore loss to follow-up, and we only focus on what we intended to do in the beginning of the trial. So all patients are analyzed regardless of what happened during the study. Now talking about per protocol analysis. So in per protocol analysis, if about 7 people are not taking my drug, the new drug I developed, ABC, then I will exclude them from the analysis. In as treated analysis, I will, so if the 7 people are not taking the drug, I will just move them to the placebo group. So now my placebo group has 57 people and my drug group has 43 people. So that is what happens in as treated analysis. And in imputation of missing values, imputation basically means just guessing. It's guesswork. So the biostatistician will make a knowledge, using their knowledge of the drug, their previous knowledge, they will extrapolate the information that they have to fill in values. That's basically, they are just assuming. So it is not appropriate. In fact, per protocol analysis, as treated analysis, and imputation, these will lead to high risk in studies. Intention to treat analysis will lead to low risk studies. Now, when I was first introduced to these concepts about biostats and analysis, I had this question: if a patient is not taking a drug, why are we still including them in the drug group? Wouldn't that create bias? So that is the question that they had when they actually introduced intention to treat analysis a few years back. I don't remember when it was introduced. They did conduct there was a study to see, like, one study conducted all 4 parts of analysis, and they found that intention to treat had the lowest risk of bias, and that is why we are following this. So it's not that somebody said this and we are following it blindly. There are studies which prove that intention to treat analysis does actually lead to low risk. Okay, moving on. Assessing incomplete. There you go. Missing data balanced across groups. What level of risk would this lead to, according to your research acumen? Now you are experienced researchers. So I would like to ask you, what level of risk is this? Missing data balanced across groups. As treated, high, unclear. Very, very interesting answers I'm getting. I want to know what level of risk this is. Low, unclear, or high? Low, it would be high. Okay. Now I want, I received one correct answer because we have received all 3 answers. I want all of you to focus on this part. Balanced across groups. Go back to the basic definition of bias. What is considered a bias and what is not considered a bias. And then answer again. Then, so in my study with 50 and 50 people, 10 people from the drug group and 10 people from the placebo group left for whatever reasons. This is what this sentence means. Would this type of loss to follow up create a bias? We are getting there. We are slowly getting there. Great. So yes, this is a low risk because it is balanced across groups. Okay. Now I have a study. I have another question for you. Would make it imprecise? Yes, exactly. The number of people would become less. It would be imprecise. Okay. Now in my study for my new drug, in the intervention group, a lot of people were very happy with the drug, and they were following it very well, and they were taking medication, and everything was good, happy and glory days. In the placebo group, about 7 to 8 people were facing more the disease was becoming more severe, and they were just getting normal saline instead of the drug. And they thought, I'm not a good doctor, and they just left me without saying anything, and they went to another doctor. Okay. So there are 7 patients who went to another doctor. They were lost to follow-up in my trial. In the drug group, I have 50 people, but in the placebo group, I have 43 people. What type of risk would this create? High risk, low risk, or unclear risk? Seven people were not happy with the treatment they were getting, and they were lost to follow-up in the placebo group. In the drug group, everybody is still here with me, following the treatment. What level of risk? Interesting answers I'm getting. I got one unclear, one low risk, one high risk, one low risk. Okay. So because number of people have 7 people have left from only placebo group, that is one hint to you. The missing data is not balanced across both groups. That is number one. Second point, the people who left the study, their condition was becoming more serious. That means that there is a very, very significant change in their condition, and that is going to affect my outcome, because in the outcome I'm just seeing, my outcome is, does the disease become more severe, or does the disease become less severe? That is what I'm seeing. And if the patients who become more severe are leaving the study, wouldn't that create a high risk? We got one yes, we got 2 to 3 correct answers. So the answer for the second question that I asked would be high risk. Please let me know in the message box if you understood this concept, so we can move to the next part. Great. Okay. So now we know about attrition bias. And yeah, so basically these are some of the examples that you can go through at your own time. In as treated analysis, we have already mentioned that it will lead to departure from the allocation. There's another point that was there. So yeah, balanced across groups, that is low risk. So you have an idea now. Yes, this is very, very important. Reason related to the, so why did they miss? Why did they leave the study? That is a very, very important question. And good clinical trials will mention the reason for leaving. They will have a flow chart and tell you how many patients were lost to follow-up, and they will give a reason for that. Reporting. So reporting bias, selective reporting. you all know what reporting bias is. Only some outcomes are reported in the study. So let's understand this better by examples. You are now assessing my clinical trial on my new drug ABC, and I have published my paper. You are going through it. I have not registered my protocol anywhere, so you do not know what I had in mind when I started my study. But I have mentioned in my methodology that my primary outcome, my secondary outcome, and this is the results, and these are the discussion, and etc. and so on. What would you consider my study as? What would be the level of risk? High risk or low risk? Interesting. So now I would like to ask you this question. What percentage of published clinical trials have a protocol published on the internet with them? Would you consider all those studies high risk? So this, whenever I am asking you 3 to 4 word questions, just have something that this is not a direct question, it's a trick question. Yes, so majority of the papers do not have a protocol, right? So by reading the study, by reading the methodology, their aims and objectives in the published paper, you make you use your knowledge to understand whether the researcher is only providing 1 or 2 variables, or the researcher has truly reported all the outcomes. So that is where your experience in research will help you. So not having a protocol is okay, but there should be very, very clear indication about what is going to be reported and what has been reported. Okay, now this is my question to you. All outcomes are reported. Now, this is also a trick question, just an asterisk in front of it. My study, I wanted to understand the effectiveness of my new drug ABC in Indian people, Indian children who were born after the year 2000. And then in my results section, you find a table which says treatment given, placebo given. And then in the boxes, you will find that there were 50 people who were given treatment, 50 people who were not given treatment, or who were given placebo. Yes. Yes. I will just mute 1 to 2 people. Sorry. Yeah. So I will ask the question once again. I have my study, new drug, given. I want to assess the effectiveness of this drug in Indian children born after 2000, after the year 2000. I have 50 children in group intervention. I have 50 children in group placebo. In my results, I have mentioned out of the 50 children in group treatment, about 80% had a good result. The severity reduced. And out of the 50 children in group placebo, about 60% had reduced severity in their disease. That is it. That is all I have provided. And in my aims and objectives, my objective was to understand the efficacy of the drug in Indian children born after the year 2000. I'm getting good answers. Low risk, unclear risk. Okay. I'm waiting for 2 to 3 more answers. Then I will give you the answer. Unclear risk. You are becoming more and more diplomatic as we move along the session. It's good. I like it. Unclear. Okay. So Whoever has answered unclear, could you tell me what would you be looking for to increase the clarity? What do you want to know more from me? What would you contact me for? So just an extra point, whenever you do not find some information in a published paper, you have the right to contact authors and ask them to provide you with more information. Measuring units, that's a good point. Yes. So I believe by measuring units, you mean the dose of the drug every child got, because as like depending on the age, depending on height, BMI, the dosage of medicines changes in children. That's an interesting point. Some measurable outcomes. Okay, that's also interesting. So by severity of disease, how do we assess the severity of disease? Symptom wise, sign wise, lab reports, imaging. Good point. Yes, so you got it, you're almost there. That is why we look at subgroup analysis. We look at what are the, so we just don't go by severity of disease. We need to mention what exact outcomes, like how was severity assessed, and we have to look at all the different points. And then measuring units, the dosage, if different dosages were given, we have to see if so all the children born to 2000, the definition of child is 13 years, less than 13 years, and after 13, teenagers, adolescents, so, or less than 18 years. What is the age group I have selected? Do I consider less than 13 as children, or do I consider less than 18 as children? And if I consider less than 18 as children, sorry, I'm going a bit fast. Okay, I'll go a bit slow. If I consider less than 18 years as children, would a child who is 2 years of age and a child who is, or adolescent who is 16 years of age, be affected the same way by that particular drug? These questions need to be answered. We can ask for on what parameter these assess the efficacy of the drug, long-term alleviation, temporary symptom. That's amazing. Exactly my point. So great, we got the answer. Now other sources of bias. You can go through these. These are some other answers. So unexpected measurements or subsets. So outcomes not reported as pre-specified or expected. So this you can either get from a protocol, or you can get by reading the aims, objectives, methodology, and you will get an understanding about what they want to look for. Other sources of bias. Let's go here. So small sample size. Would this be high risk, low risk, or unclear risk? There are only 3 words in this question. It might be a trick question. Asterisks. Okay. We have one answer. I'll wait for 2 to 3 more answers. It's not a bias. Yeah. Unclear risk. So yeah, it's not a bias. It's an imprecise study. Precision and accuracy are 2 terms. If a study is not accurate, that means the result of the study deviates from the correct answer. So when a study is not accurate, a bias is present. Now, when I talk about precision, if this new drug was given in my subset of patients, but if the same drug is given to other people, other children in different countries across the years, would it have the same effect again and again and again? Or when this study design has been implemented in different children across the world or across timelines, would this have the same effect? If no, it is an imprecise study. So imprecision will deviate your results either towards positive or towards negative. Accuracy will deviate your results only towards one direction. So when I talk about small sample size, it leads to an imprecise study, low power. Okay, it's 1 minus beta. I'm just going into a lot of technical terms. I won't go into a lot of technical terms. So that's it. Now let's talk about this. I conducted this study. I just wanted to conduct, but my IRB wouldn't give me ethical approval. But I just went ahead and did the study anyways. And there is no ethical approval attached with my study. I just submitted it. Would this create a bias? And what type of bias? What level of bias? High risk, low risk, or unclear risk? No bias. No bias. Amazing. You guys are amazing. Okay, moving on. Inadequate dose. So let's move on from pediatric because this question might create an issue. Let's go to adults now. So usually in adults, we give the same dosage to everybody. Now, instead of, let's say my medicine works when 20 milligram of it is given to people. And I'm comparing it with the current gold standard. So my medicine reduces fever. That's what I claim. And by giving 20 milligram of my drug, fever will reduce. And paracetamol is the current standard, let's say. Paracetamol is acetaminophen. So paracetamol is the brand name of acetaminophen that is being used. So that medicine, 500 milligram, let's say, is standard. And I am just giving 100 milligram of acetaminophen to my gold standard group. And I'm giving proper 20 milligram to my intervention group. Would this create a bias? And if yes, high risk, low risk, or unclear risk? So yes, in this particular scenario that I just mentioned, patients will react better in group A who are receiving 20 milligram of the new drug. Patients who are receiving 100 milligram of gold standard would not feel the effect, basically. So it will create a bias because the results are being deviated to one direction. If I am giving 10 milligram of the new drug instead of 20 milligram to intervention patients, and if I'm giving 100 milligram of gold standard to the gold standard group, then that won't create a bias. So in that case, there won't be bias. It will be a low quality study or an incorrect study. But the term bias will not be applied in that particular scenario. Okay, last, non-randomized studies. If I'm not conducting randomization, so random sequence generator, we just read. So in my non-randomized study, would it create a bias? It can't be so easy, but okay. High risk, all right. Yes, it may create a bias, okay. Awesome. Let's move here. So it does create a high risk of bias. And there are other examples also. But let's not go into details. Let's not go into technical terms like blocked randomization, clustered randomization. We'll understand that later on, but let's just focus on the basic things that we need to know. And now putting it into practice, we will stop this session today and we are going to continue it next Sunday, same time. Yes. So before I end this meeting, this is what I wanted to show you. So these are the different assessment tools that you can use. There is grade, there is ROB2. We just discussed ROB2. there is Robbins, and etc. Newcastle, Ottawa is used for case control. ROB2 is used for randomized clinical trials. There are other studies for non-randomized clinical trials as well. Then we have here, AMSTAR. So if you have attended the previous master classes, you would know that there are different types of reviews that are being conducted. Umbrella review, systematic review, scoping review. If I'm conducting an umbrella review, what do you mean by that? That is systematic review of systematic reviews. So if I'm reviewing the different systematic reviews published, then I will be conducting my risk of bias with these tools: Robbins, AMSTAR, Robis, etc. Question in the chat box: what if multiple types of studies are included in a study? Yes. So if in my systematic review, I have 8 clinical trials and 10 observational studies, I will use the ROB tool for 8 clinical trials, and I will use the Newcastle, Ottawa tool for the 10 observational studies. And I will mention that very clearly in my results section. The ground is open for questions. So I'm going to, I will try to answer as many questions as I can. And till we get all the other questions, I will provide you with a task. Separate analysis will be done. Yes. So there is one saying that goes in systematic reviews: we cannot compare apples with oranges. We can only compare good apples and bad apples, good oranges and bad oranges. So we can only compare clinical trials. Oh, okay, awesome. So you got the answer. Talking about your homework task. So let me open this. Yeah. These two things I want you all to understand before we begin the next session. So I will provide you with this. I'll provide you with a link to this PDF. And this PDF will tell you how to fill the ROB Excel sheet. Let me share with you. I'll share with you a glimpse of the Excel sheet. One moment, please. Yes. So this is the Excel sheet I'm going to share with everybody. This is how it will look. And we are going to understand this, how to add information. And we are going to do that with the help of an example. Before I take new questions, I'll stop recording. And everybody who is watching this recording, please go to your groups, your respective groups, and you will get information about the homework tasks that you are going to complete. Researchers who are joining us from Remed Kenya and the Health Drive Foundation, I will provide material, your homework tasks, to your respective mentors. Okay, then I will stop recording.